It's April 20th, 2021, and this is live SEVA VentRounds. And today we're going to focus on reading cycle synchrony. We'll do the usual read, but I thought that it would be good to talk a little bit about cycling on mechanical ventilation. Disclosures, we discussed particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. We're agnostic to these things. Just give us a ventilator and we're happy to talk about it. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. You can see my conflicts of interest and Rob's, Chatburn's conflicts of interest. The ground rules is these are recorded sessions. So keep your microphone muted through the interactions unless you want to speak up. That's excellent. Just we don't like the barking dogs on the background or whatnot. I'm the moderator as well as Rob, and so we may call upon members of the audience to comment. But if this is an open forum and we want to hear your interactions. This is a safe space, and I have said this before. I mean, we're all here learning, and every time we do one of these, we learn a lot. Do use the chat function of WebEx, and what you will see is that we also use a WebEx poll to elicit audience interaction. And for the Cleveland Clinic employees on RTs, you can get CMEs, which you can translate into your equivalents for education. And so I'll give a QR code at the end of the session. I always like to ask at the beginning, where are you joining us? And we've had people as far as Hong Kong join us. So if you want to share where you're coming from, just type it on the chat. We love to see who's out there and just make a community that learns along on mechanical ventilation. So today I decided to go back to our basics of whenever we read a waveform of mechanical ventilation, and this one will not have a tutorial as we usually do, but it will end up being a tutorial at the end. So just for the sake of everybody that is joining, we have a standardized method of reading waveforms, and we start by talking about the tag, which is essentially describing what type of mode it is by looking at the waveforms, or if we have the mode, then we use that. What is the load, meaning if it's more elastic or resistive, or the PMOS, and if there's any patient ventilator discordance, trigger, inspiration, cycle, and expiration. We go in order. So having said that, I'm gonna put the poll out for you all to get at it, and just now it's open, and I'm going to keep it open for a minute or 2 minutes. Just look at these waveforms, try to tell us the tag, what is the load, and then the patient ventilator discordance. Now this poll does not have the expiratory phase, but we can talk more about it. So try filling it up. I'll share the results at the end. I see at least 10 people are trying to go at it, so have no fear. And these are waveforms from live patients. These are non-modified. Actually, you can see the lower quality of my pictures is that you can see the reflection of what we were taking up. So some of them will be crooked, and I apologize about that. 20% of the people have finished. We have 30% going at it. We're gonna give you 30 more seconds. And I'll ask any of my fellows or RTs, if anybody wants to jump in and be our reader, we're happy to do so. Just either text me or chat or unmute yourself and get at it. All right, Chip, you're the first one jumping up. I'm gonna. So the poll is closing right now. I'm gonna share the. Do you want to see the results, Chip, or you want me to show them at the end?
Let's show them at the end.
All right, go for it.
All right, so the tag I'll say is PCCMVS.
Sorry. Very good. What else?
All right, the load for inspiration. You know, there is like very mild PMUS here, but nothing really crazy. But I'll say some PMUS for inspiration, and then expiration looks pretty normal. So if anything, I'd say maybe some elastic. I don't really see any work shifting in the expiration.
Okay. And what about the patient ventilator discordance?
Yeah, the trigger looks normal to me. Inspiration, there is, you know, very mild, if any, work shifting. And then there is a late cycle and normal expiration.
Okay. Very good. All right. Let's dissect this. First, let me share the poll results with the team so that they can see the answers that we all had. What I'm reading here is of the people that answered, essentially all of them agreed with your tag. They said that this is pressure control. On the load, there was a split. A large amount of people thought that there was a resistive component. And there were some that thought the second best option was PMOS. Majority of people thought that this was a normal trigger. Majority of people thought that the inspiration was normal, and some put a little bit of a mild to moderate work shifting, so 3 of them. And the cycle, the majority of people recognize this as being late. And so go ahead. What do you think, Chip? Can you tell us why you came out to the conclusion that this was PCCMBS?
Well, the flow, you know, has this sort of exponential decay, and then it kind of goes to 0 and then doesn't really cycle. So there's not going to be any flow controlled mode of ventilation that does that with the flow. So this is going to be pressure control. Okay. CMV, because each breath is triggered and cycled by the ventilator. And if you couldn't tell if it was triggered, I mean, at least you can see it's late cycled. So that's, you know, by definition would be mandatory. And then set point, I would say, just because I don't see any change really in the pressure delivered or the volume delivered, but there's little, if any, patient interaction. So adaptive would be tough to say.
Excellent. Yeah, I think that you're right. Do you think that the breaths are machine triggered, correct?
Yeah, I think they're machine triggered.
Yeah, I think that you're right. The one that knows the best is obviously the ventilator, and we don't see any change that they usually have to let us know that there was any type of triggering. So I think that definitely this is a machine trigger patient, and I'm sorry, a machine cycle, which definitely makes it a mandatory breath. And it's for every single one of the breaths. So it's pressure control. This pause that you mentioned down here, can you do that on volume control? Can you get a pause at the end of the breath?
You can, but you wouldn't see, I think, like another increase in flow there. Exactly. But you can add like a short pause or however long you want.
Yeah, excellent. And that's the key observation there, Chip, is if you put a pause, an end inspiratory pause, in either, you can do it either on pressure control or on volume control, the flow would be 0 under those circumstances. And you can see that here we can see some oscillations on the flow as if the patient was perhaps inhaling during that period of time, correct?
Right.
And then your eye keenly recognized that there was some PMOS. Can you guide me where you saw the PMOS?
I mean, it is like the most mild PMUS of all time, but the flow degradation really looks more linear than exponential. So I mean, there's I think a very small amount of PMUS there, and then that increase in flow right at the end there is also kind of interesting. But that's really it.
Yeah, so I also have trouble looking at this because I was trying to, yeah, I mean, obviously what Chip is talking about is we're trying to have this is the worst color I could have chosen for this graph. Let's try red. So you're trying to, you have a rapid rise on the flow, and then you would expect a exponential decay on the flow, and instead of that, you see that more straight. Here you kind of see that curvature that you're expecting here a little bit higher, and that makes you think, is the patient doing PMOS? Because normally anything that moves up signifies that there is some patient effort. Otherwise, it should decline nicely. Is there any other reason that can give you this hump in a patient that was paralyzed?
Well, I suspect yes, but let's see. Why would you have an increase in flow? Oh, maybe if some airways popped open, you'd get like a sudden increase in flow there. No, you get a decrease. No, yeah, I'm sure there is, but I can't think of it.
Yeah, so you're talking about some of them, right? So if the compliance and the resistance were not linear, and there was a change in the characteristics of the lung, either because there's recruitment, and so then suddenly there's an increasing flow in those areas. It could be also that there is a leak, can also give you an increase in the amount of flow getting out of the system. And that's a little bit tricky to catch. So there may be intertidal volume recruitment, or changes that change the compliance and resistance. Instead of having your nice, beautiful decay, you don't have it. Aman is commenting that if the patient could have early trigger, this would be a classic picture, right? So if it's machine triggered and then you see evidence of PMOS, then that patient may have early trigger, which in this case in particular, the patient, as Aman is highlighting, was paralyzed. And so when you have a paralyzed patient, then you start thinking, well, why do I have this abnormal waveform? And there's perhaps another hint over here that you can see that can tell you what else was happening during peak inspiration. Do you see the hint? Chip?
Yeah.
What does this mean usually?
Leak.
Yeah, so at peak inspiration on this patient, there was a leak of the amount of from the cough, and then he comes down and then exhales less of the tidal volume that he was receiving. So that's why I don't think that there was PMOS necessarily on this patient. It was just either diffuse changes in compliance or a leak. I don't know if Rob is on the line. I don't see him today. But that would be my interpretation in this paralyzed patient. But that's one. So I do agree completely with you that these would raise my thought of saying, is the patient having any PMOS? So that's the first thing that you want to rule out here is if there's PMOS, and other causes could be, as I said, changing elastance or recruitment or leakage that change the flow. All right. Does that make sense, Chip?
Yep.
All right. Excellent. And then so this patient is paralyzed, and so the trigger is normal because there is no patient interaction. So essentially, the machine is triggering. The inspiration, we just talked about that. This is one of those situations in which you may look like, and you were. That's what I applaud, is you caught the abnormalities and read them as work shifting, but indeed this may be just the leakage, and then you have cycle, which is late. And can can you think about, I mean, usually when you're paralyzed and you have a late cycle, what would be the indications to have a late cycle? And why would you make the patient have a late cycle?
Well, it'd be akin to like an inspiratory pause in a volume control mode. So maybe if you were trying to provide a short time for further gas exchange to take place.
Excellent.
Might.
So, very good. That's one. What else? And team, please, if you feel nice on writing any other thoughts on the chat. But yes, one of them is just definitely gas exchange. What else does it change on your pressure when you give an end inspiratory pause?
What does it change on your pressure?
Yeah, so it actually Richard Ball just put raising the mean airway pressure. So that's another way. Remember that mean airway pressure equals, in a sense, oxygenation. So the higher the mean airway pressure, the higher the oxygenation. And so the other fact, as you call this, by leaving prolonged or creating the pause, you improve gas exchange, mainly CO2 clearance, by improving exposure time or gas exchange. So in these circumstances, although the cycle is late because the flow has ended, this is a choice of the caregiver to do that for this patient in particular because of those two reasons that I can think of: gas exchange, i.e. CO2 exchange, or oxygenation. And then you were 100% correct on the expiration. It's completely normal. It returns in 1.2 seconds, 3 seconds. Questions, Chip?
Nope.
So outstanding job as usual. I'm reading the rest of the comments, and I think that everybody got it right. There's a question: will late cycle or inspiratory pause help oxygenation or ventilation more? Yes, Udi, that's exactly the point. All righty. So I'm going to ask if there's anybody else that wants to jump on. I'm gonna do the one in which you choose to jump into the discussion and read the next curve, and then I will show it. Anybody? Maybe if I show it. Right, I'll show it. There you go. Anybody wants to read it? All right, I'm gonna put the poll while I get some. Here we go. Oh, what did I do? I erased the poll. Sorry. Here we go. Oh. All righty. Get to read this, and if anybody's interested in reading, please let me know, and if not, I will read it on my own, and I'll walk you through it. So start answering. %27 are doing it right now. Alan, thank you for asking for annotation, but I have to decline the request because if not, you take control and the things start appearing on our screen. All right, we have 30 seconds left. Keep going. 7% has finished. Good job. All right, it will close in 20 seconds. And I will start reading it in absence of.
I can do it.
Okay, who's this?
This is Aman.
Aman. All right. Thank you, Aman.
All right.
So
So
go for it, and then I'll show the results from our team. Okay.
okay. So I think the tag would be PCCMVS. Load would be inspiratory PMAS. Expiratory is a little bit challenging. I'm gonna say resistance. It may be PMAS as well in some of the breaths, but like the last one looks pretty passive, and it doesn't go back to baseline. So between those two. PV discordance. So trigger, I would say normal. It's a flow trigger. Inspiration has work shifting. Not a whole lot, but like moderate. And then cycle is late in a few breaths. The flow returns all the way back to normal in breath, like first, second, and the fourth one. And expiration, I'm kind of like not sure, but I would say passive, so normal for the most part.
Great job. So, I'm gonna increase the odds because a little bit and tell you what would you do if this was your patient and he was and your goal was comfort. What would you do for him?
So for comfort, I would. It's tough to say. Seems to me like there's like, maybe a little bit more work shifting than I would, that would make me want to do something. So I might want to increase the support a little bit. If I think the patient's not comfortable, like go up on the pressure. That's one thing. And then obviously, I would probably shorten the eye time a little bit.
Okay.
Because of the late cycle. But
very good. Thank you, Aman. Yeah, great read as usual. So let's walk through. So you read this pressure control. You rapidly recognize that this flow is not controlled by the ventilator, and it's by a process of elimination. You rapidly can tell this is pressure control. The ventilator are mediocre at controlling the flow. The pressure, very good at controlling the flow. So in this case, the ventilator is trying to control the pressure. Who's triggering the breath? You read it very well. It's a flow trigger. Here's the color change that indicates us that this is being flow triggered. And you actually can see textbook deflections down on the pressure. Actually, if you think whatever pressure this patient is getting, he almost gets to baseline, which is 0. Which is a good amount of effort from the patient at the beginning of the breath. So he pulls in intensely. The ventilator pressurizes the system as fast as it can, but the patient is pulling harder than it can. And then the breath is cycled by the machine. So it's patient trigger machine cycle. And we know that because actually there is this period of time that looks like a pause, but it's simply the eye time. And you can actually see, because the patient has variable inspiratory efforts, right? The cycle time is different size in this little pause that it's occurring because the patient finishes breath is different sizes for each one of the breaths. So this is CMB without a doubt. And then set point, it's really hard for us to say just on this strip if there's any intelligence into the mode. And so set point would be a safe bet for this patient. Any questions there, Amanda? Any comments?
Nope, makes sense. I mean, I would say that to distinguish this from pressure support, this is, the flow is coming back to the baseline, so it cannot be flow cycling. So has to be a CMV and not CSV.
Absolutely, that's a great point. So that's the difference between this one and PCCSB and CMB. And actually, this touches on the issue that Richard put on, is if the pressure scalar drops below 0 at the beginning of the breath. Sorry, I pressed the wrong button. It says either in PCCSB or CMB, how would you describe this? Severe work shifting, as it can be flow starvations in PC, can it? And so this is a great question. So this is work triggering work, right? So the patient is doing work at the beginning of the breath, and the aim is trying to decrease the amount of work that the patient is developing at the beginning of the breath. And there's some things that you can do, like decreasing the rise time on the ventilator so that it delivers the pressure as fast as it can, so that the time with the pressure below the baseline is minimized. But this is that's one of them. The other one is increasing the support, the amount of support, so it pressurizes. However, sometimes increasing the level of support may not even get rid of this, because the patient will still have it's not delivering the pressure at the speed that you want. But we'll talk a little bit more about that. The PMOS during inspiration, you're 100% right. Instead of having your nice decay that you would see here, exponential decay, you see how there's this hump, and that is definitely due to effort, and that's also confirmed by the drop that you see here on the pressure in the inspiration during the initial part of the inspiration. And then in expiration, you read this. It's a challenging one. I agree with you, Amand. This one is easy, perhaps because it's kind of shorter, so it seems that he may be doing some effort instead of the nice decay. But you see the very, very appropriate decay that it's occurring. So it makes me think about increased resistive load during expiration, and then rapidly they are shifting into inspiration. So although this may look as auto PEEP, and there may be some degree of auto PEEP, this may also be just a shift from expiration to inspiration rapidly with some evidence of PMOS. This one is always caused some challenges in my mind, because they look like an exponential decay very nicely here. And so the key is grab your stethoscope, you listen to them, assess the AT2 patency, see if there's expiratory muscle activation in the abdomen, in the chest wall. That will help you kind of define that. But so I think that your red is right on. It's resistance would be the first thing that I want to rule out, and or the presence of PMOS. Questions there?
Sounds good.
Then there is the PV discordance. We talk about the trigger. I think it's normal. I agree with you. Even though there's this big drop, the machine is pressurizing and delivering flow immediately when it crosses the baseline. So that makes me think that this is just intrinsic patient effort, and the ventilator is trying to pressurize as fast as it can. You recognize work shifting, and I'll show you. I think I have an example later on of extreme work shifting actually during pressure control, so you can see actually flow starvation during pressure control because the patient effort is so big. And then you recognize the late cycle appropriately, and expiration we talked at and so I think that these are the two items that I would change. And I think that this is very similar to what people are putting as options for the ventilator, including liberation from the ventilator. But in this time, pressure support is another alternative, so that you don't have to deal with the I time. And so using pressure support, PCCSB S would deal at least with the I time, and then you can increase your support as needed. Aman. Any other, let's see what the audience read this and go from there. So the majority agreed with you, Aman. This was a PCC MBS. Some followed by adaptive. And what I would tell you about adaptive is that it's hard for me to say that on this screen because there's no change on the inspiratory pressure throughout. And the patient is doing majority of the effort. And so this makes me suspect that this patient is getting actually a fair amount, a good amount of support here. And although he's doing pretty consistent effort, so I would expect some oscillation or up and downs on the pressure according to the goal. So that's why it's hard for me to say it just on that look. The load, you had a good amount of people support your resistive and PMOS. PMOS was the main dominant one during inspiration. And then the trigger, they read it as normal, inspiration as work shifting, and mild to moderate. I agree with that. And then the late cycle, almost all of you got it right because now we're recognizing that feature, that pause at the end. Great job. All righty. There's somebody, yeah, I agree with you, Megan, Alicia. If that, with that much effort, you would expect the pressure would decrease if adaptive. Correct reads. All righty. Let's see another one. This one with, I'm gonna open the poll.
Dr. Mireles, I can go on this one.
All right, thank you, Samir.
UD.
Yes, this is intense. Wait, I'm saving stuff that I pressed the wrong button. There is some tricks on when you're doing this polling that I'm gonna get better at. Here goes, open poll, go at it. Samir, this is your moment of thinking about this.
Dr. Mireles is UD. Should I go ahead?
Oh, this is Udi?
Yes.
Oh, give me, sorry for baptizing you with another name. Give me 1 second while the poll is going. We have 1 minute left. Subhan, I'm gonna decline the request to annotate just because it makes stuff come up on our screen. Sorry. Team. Good. I see a good amount of you are now getting into the poll. This is good. This is a good moment for you to test what you're reading. And again, these are all anonymous, so I have no idea who's answering. And this is good. Test yourself against Udi. I'm going to close the poll. You have 20 seconds left. 10 seconds. All right, Udi. All yours, my friend. Guide us through what you read here. Again, safe space. Don't worry. Just tell us what you think.
Okay, I apologize for getting it wrong ahead, but
you shouldn't. I applaud you being here. Go for it.
So I'm going to kind of follow the kind of algorithm in my mind. So the first thing is I look at the flow, and the flow does not look very controlled. So I think that this is pressure control. I would think that the pressure wave also confirms that. I think it's pressure control, but there are these negative spikes at the beginning of the pressure control. The second thing is the breath sequence. Is every breath the same? then it's not IMV. So I don't. So I think that every breath is the same. So this is not IMV. So they think this is CMV, and especially because you can see or cycling, a bit of early cycling, and the flow gets cut off. So I think this is CMV. Looking at the targeting scheme, I look at the control variable, which is the pressure, and I see that it does not change within a single breath, that within breath target is the same. So it is not dual, but it does not change from breath to breath. So between breath target is also the same. So it is not adaptive. So I think it's set point. So yeah, that's my tag. What is my load? I think they've considered a PMAS. For inspiration, there is PMAS. On expiration too, I would say there is PMAS also.
Okay.
Trigger, I think the trigger is probably pretty, or trigger is like, I would say normal. Yeah, I don't know. Inspiration, I think it's normal, but cycling, I would say there's early cycling. And expiration, I think there is expiratory word shifting.
Okay. All right. Thank you, Udi. Let me ask you before I show the results from everybody else. If your goal was comfort on this patient, or just simply you walk by this patient, what would you change?
I think I probably increase the eye time. I think it's cycling early.
Okay.
And I think that it's, yeah, I think there's close. I think the patient's still trying to take a, yeah, I think early. That's the first thing I would probably change.
All right. Thank you, Udi. Let's see what the poll showed. I'm gonna share. You're now the host. Okay. Poll results apply. I'm sharing now with you the results of the poll. Oh, there's a bar graph that you can do. Well, I cannot. So what we know is that the majority of people chose PCCMBS. Some people chose volume control CMBS, but I think that you recognize very well, Udi, that this is pressure control, because the flow is not controlled at all under these circumstances. The load, majority of the people recognize PBUS, the trigger as normal. The inspiration, some mild to moderate work shifting was the main answer, some severe work shifting. And then in cycle, the majority of the population recognized early cycle. So great job, everybody. So let's go over this, Udi. So yes, indeed, pressure control. I think that you are absolutely right. Every single one of the breaths that we are looking at is patient triggered. So this is patient and patient trigger. That and actually you can see the next one is also with the classic drop on the pressure waveform. That doesn't mean that you may see it, and this is not the pathognomonic of patient triggered breath. The thing that it is that tells us that it was the patient, or that the machine thought that was the patient, is a change in color on the waveform, and each ventilator has different. And this particular ventilator changes the color to, and it changes actually. Some of them have it pink, orange, white, whatever. So here you go. And then the question is, it's machine cycled under these circumstances because the flow, or so here's the question for you, and it's a little bit tricky. Is could this happen, Udi, if this was a CSB breath. How would you differentiate between CSB and CMB here?
If it's CSV, then I mean, if it's CSV, then it would be patient cycled. This is machine cycled, right?
Well, but how would you recognize it?
It would come down to the baseline. It would not.
Well, it all depends, right? So that's the trick question. It would mean that there has to be something here. So what makes the breath end here? If it's one of the options is that it's I time, right? If it's inspiratory time, as you read before, then this would be CMB, right? Because it's a mandatory end. But the other option is that this would be the percent of the peak inspiratory flow, right? And so then you could, if I set it too high, so normally it's set on the ventilator between 25 and 35, but I could have made a mistake or just by choice of happiness, I could have chose 50% or 35%. So I could be cycling early also under those circumstances. Does that make sense, what I'm saying?
So you're saying that you could cycle early on CSV if my flow trigger, that's the percentage of flow was put in incorrectly.
Your cycle threshold, which would be the percent of the peak inspiratory flow.
Okay.
Yeah. So and Mariam is bringing a good point as well, Eduardo. This could be the case, but all the breaths seem the same size, right? And so under those circumstances, you would say, oh, okay, yeah, if they are all the same size, that also speaks towards CMB because every single one of them look to be same distance. Now, Chip and caught with his keen eye a statement down here that it's sabotaging your existence. And so in this setting, it's asking for the tidal volume, and you know that this is not volume control. So what mode could be doing something along these lines, in which you set a tidal volume and it's pressure controlled, and
Adaptive.
yeah, exactly. So this was not on intent. I mean, the only way that you can read that is because I sabotage and put this down here. Well, it was not intentional, actually. I picked on it, but that would be a cause for it. So that this patient had either CMBA or CSBA, and that's why there's a backup rate and backup situations. But that's something for you to be aware. I don't want to go completely into it, but I want you to be aware that this can be a machine or a patient cycle breath. And we're going to go right now with CMB because it doesn't really matter under this. You recognize very well the load, which was elastic during inspiration. Elastic PMOS. There's a lot of effort for this patient during inspiration. And then during expiration, you talked about PMOS during expiration. Are you referring to this part, Uri?
Yes.
Yeah, and absolutely. I think that's the patient is doing an inspiratory effort. So you can see how the flow approximates the baseline. And when it approximates the baseline, that means that the patient is doing an inspiratory effort. What would have happened if this had crossed this line over here? What would have happened, Uri?
It would trigger another breath.
Exactly. And it did not. So that's an inspiratory effort. So it looks actually, yes, as a false trigger, but it's not a false trigger because this is well, actually not a false trigger, a failed trigger. It's not a failed trigger in this case because it's still the same inspiratory effort. The patient was still, it's a long inspiratory time. So if I would draw the muscle activity here, and you can actually would start over here probably like this. This is a spindle of muscle effort. it would still be occurring all the way to here. And so it's the same inspiratory effort. Does that make sense? So it's a longer effort. So that's why this is early cycle rather than a failed trigger. Although a failed trigger may look the same, but in this case, we have evidence that there was effort all throughout the inspiratory cycle. So the trigger was normal. There was during inspiration, there's not much work shifting, but you know there's work shifting because actually this patient is generating effort and then hence work because he's generating volume. So there's some mild or there's a degree of work shifting if you want to mention that. You read very well the cycle, and then expiratory work. It's actually this is inspiratory work. After that, it looks like a very peaceful exhalation with some cardiac oscillations there. I think that yes, you're absolutely right, Chip. This is the mode for this is PC CSB A, but it's difficult to take a look at that. Very good. Questions? This is the moment to ask. Yeah, and Udi, this is a good question that you're putting. So remember that in adaptive, you're controlling in between. So if we see if the tidal volume is within target, in the next breath, it would maintain the pressure at the same level as the prior one. So it's a in-between targeting scheme. So yeah, good points. Now, well, we'll leave that for another SEVA rounds because there's some abnormal behaviors with these types of algorithms, but we don't need to talk about that right now. All righty, I'm gonna put on the next one. I'm gonna open the poll for all of you to be able to choose. Sorry. And you can start answering, and if anybody wants to jump in, if not, I'm happy to read it myself. But if anybody wants to read it, just let me know and we'll get you in. But let's start answering. I'll give you another minute. By this time, you guys are experts in cycling, but this one has a lot of data. Keep going at it, have no fear. Maybe I should put some music while we're waiting for these things to close. All righty. Anybody wants to read this?
I can make an attempt at it.
Oh, hey, Steve, how are you?
Good, good. How are you?
All righty. I'll show the poll results at the end. So go at it.
Okay, so it looks like it would be pressure control because the flow waveform is not constant, and it looks like there's a fixed inspiratory time. So I'm going to go with PC, and the fixed inspiratory time also means that they're not all patients cycle, which makes it CMV. So I'll go with PC CMV. The load, it looks like there's a lot of effort kind of all throughout, which makes me think that T mus is probably the predominant load. And then I'll move on. NPV discordance, trigger. So there, towards the right side, it looks like the patient triggers kind of a couple times in a row. And I think there might be what is a missed or a failed trigger, I guess I should say, somewhere in the middle. Yeah, right about there, where the pressure waveform goes down and the flow waveform goes up, but it fails to trigger a breath. So anyway, so there's the failed trigger, and then there's some repeated early triggers later on. And then inspiration, there's not a lot of work shifting. Cycle, we'll go with late in almost all the breaths. And expiration, I guess there's a little bit of expiratory work. It's not exactly the normal deflection, but it's not anything crazy.
All righty. Thank you, Steve. What would you do to help this patient? What would be your action after what you have read?
Well, I guess it's a little bit concerning. There seems to be some type of severe dysynchrony, as we described, and I guess the failed trigger is always concerning for auto-peep, although there aren't really features that are super like screaming auto-peep here, but there's that, and they're kind of repeated breaths. So I don't know. I think it depends. If the goal was safety, I would sedate the patient more. If the goal was comfort, I might try something that's more comfortable, like spontaneous mode of ventilation.
Okay. What mode would you choose?
I guess what I normally do is just try starting with pressure support, so PC, CSV, S, and then see how the patient does.
Very good. Thank you. Let's read this, and please stay, because there's a lot of good discussion here. So, outstanding read. The majority of people read this as PCCMBA. There was PMOS as main thing. In terms of the trigger, some people recognize early trigger, some talked about late, and some about failed. So there was a different interactions, work shifting as mild to moderate, and then the cycle was recognized as late by all of those that actually answered that question. So it seems that that's the message about cycling has gotten through. So let's start by the PCCMBS. You recognize that this is a patient trigger breath, right? And this is patient, and this is patient. But we know that this is machine cycle because there's it's cycling at whatever time the machine we set on it. So it's machine cycle. So it's definitely CMBA. Can we read if this is a if there's any change on the pressure throughout the breaths? Do you have that ability to see that, or not necessarily? What are your thoughts here? Somebody thought that this was adaptive. What would you say to that, Steve?
I guess I don't feel like I could say for sure that it's not, but I don't know if I can say for sure that it is. Because it's possible that there's a change in the pressure, but it's also possible it's just, the ventilator's difficulty in controlling it precisely.
Yeah, it's challenging. I like to see always my volume waveform. So you can see that the next one, he almost got 700. To the next breath, he got less tidal volume, but the pressure, at least between this one and this one, seems to have pressurized at the same level. But I agree, it's hard to read that. Admittedly, the goal of this exercise was not to necessarily focus on the tag, but it's always good to go through it. The load, I think that you recognize appropriately the PMOS during inspiration. I mean, the patient is doing a large amount of effort during inspiration, and during expiration, at least on this one, with the exception of this, I don't think that well, this one is definitely patient effort. You can see that it's not decaying nicely. And so I think that this is PMOS combined with probably normal, but I cannot necessarily say there's enough PMOS and incomplete waveform tracings. In terms of the trigger, what type of trigger is this patient getting, Steve?
This would be a pressure trigger because
Yes.
you see the white deflection on the pressure waveform.
This is a pressure trigger. And I want you to take a look at this because so you see how much the patient is having to drop the pressure to trigger, and then here he has to drop all this amount and this amount on this one to trigger the breath. And then here, because it's a pressure trigger, the patient actually did enough effort to cross the baseline, right? You see how it crosses the baseline on the flow? And it dropped the pressure on the airway, but because it's a pressure trigger, it was not able to reach the threshold set by whoever was the operator. And even though it dropped the pressure, the patient could not trigger a breath. So this is one of those types of failed trigger that it's not related necessarily to auto PEEP. It's related to the threshold set on the pressure trigger for this patient. Is that cool?
Yeah, that makes sense. So in theory, the solution would be just to reduce the trigger threshold.
Exactly. That's the case. I mean, and sometimes people choose to do this to use the pressure trigger to decrease because if the patient has a leak or if there's violent cardiac oscillations that are creating oscillations on the flow. I mean, I can see that happening, but this is one of those events in which this failed trigger in particular is due to the pressure threshold. So what do you think about this other, any abnormality with the other breaths besides that failed trigger?
Well, I guess the shapes are not really normal. I guess the pressure breaths, there's that little bit of work shifting and inspiratory work. And then, yeah, the shape of the inspiratory waveform is kind of funny. And the shape of the expiratory waveform, especially toward the right side. But other than that, I'm not really picking up anything specific.
Yeah, so this is a classic challenge. So in terms of work shifting, I think that definitely the patient is doing inspiratory work, right? So but the machine is triggering immediately after it reaches, boom, it goes up. Now, whenever I'm looking at these waveforms, it's useful for me to know what was the set inspiratory pressure. What was the set inspiratory pressure? And I could bet that probably on this patient in particularly, the inspiratory pressure was set around this level, around right here, for each one of those breaths. Because that's where the ventilator is stopping the pressurization because it reached the goal, then it comes down and then it goes up. And all of this is above what the ventilator was trying to control. Why do you think is that happening, Steve?
I guess it's a little bit tricky. So
look at the flow. The flow is your answer.
Maybe the patient begins to fight the breath. The patient begins to expire.
Exactly. So as the patient starts relaxing they exhale rapidly. So that gives the first rise, and then the patient is trying to exhale is the thoracic wall, and they find a valve that is essentially closed because the I time is too long, and so the pressure is going to be higher than what you set on the inspiratory pressure, and that's a marker of late cycle on these patients.
I see. So this is kind of a severely late cycling, and the patient's spending a lot of the inspiratory cycle fighting the inspiration.
Yeah, going against and there's as you can see here, what this is telling you is this patient is not exhaling, that we have the valve closed. Even though he has finished, the valve is closed. I don't care what the patient is doing. We're not going to let the flow go out. And that's why you see no change in flow during that period of time, which means that you are your system is going against your chest wall, and your lungs are trying to recoil against a cold closed valve, and so you see the pressure rise up. That's what this means. That's what you expect to see, and that's what you're seeing there. And then the patient exhales, boom, and then it decays exponentially until it has this work event from the failed trigger. And this one is definitely an expiratory work. So with that, it's 3:01. I want to congratulate. I mean, you guys are reading this better than ever. Great job, Steve, Aman, Thin, and Uri. Did I say Aman and Thin? Okay, and Chip, for your readings and logging on today. I'm gonna put the code for you guys to get your CMEs. Please scan that. It's right there. And if you see any waveforms that you're interested on us reviewing here, I love it when you send it to ourselves. So just email us, tweet us, whatever you want. Thank you very much. Great job today.